Right. National Program for the Cancer Control, Diabetes and Stroke. Under this, what is the recommendation? There were at least some 6 programs which were asked in this AIIMS paper. Program of control of blindness, etc., etc. So, this is a paper of programs. Under this, Cancer Control, Diabetes, Stroke program, at sub-center what they thought of doing? NCD means you know non-communicable diseases control, which are not infectious. Sub-center level may screen for the BP, sugar, refer suspected cases to the community health center, etc. CHC level may what do you want to do? Diabetes, stroke cases, etc. Outpatient basis you can manage. Home based care for the bedridden chronic cases. District level may what to do? You can do kidney function test, liver function test, ultrasound, mammography, everything. Daycare facility, etc. Then comes the tertiary care. So we have state NCD cell, district NCD cell. Then we have a block CHC, Rogi Kalyan Samiti, and village health committee, which will take care of the sub-center level. This is how non-communicable disease management pyramid, this is what need to be remembered. Now this is another interesting question. You need to have a lot of willpower for preventive medicine. For entrance exam, you must for some time think in a nationalistic spirit of patriotism, whether you have or not. And then dwell yourself that after MD, I am going to be a perfect government doctor. That's one way. Or you can go into hallucination. I am the WHO consultant. After doing MD, I am going to travel to Jamaica, so many countries in a chartered flight. Let's put some good things in the dream, because entrance is not really that good a dream to dream. So all that, and then open park textbook. Otherwise, very difficult. Huh? Question number 50. What is your answer? You like to say A? Under RCH program, all are given except A. A. Question number 50. Kamal, Nikunj, Gaikwad and Kavi. Everyone is saying mebendazole. They are against it. See, give a single dose of any of the following is the recommendation. 200 mg albendazole for children aged 12 to 23 months. 400 mg albendazole single dose for children aged 24 months or more. 100 mg of mebendazole twice daily for 3 days for children aged 24 months or more. This is the recommendation. I am not sure what was there in the frame of the question. Vitamin A is very much given. Vitamin A is given as a single dose to all the SAM children. Now, with regard to the infectivity, how long are the diseases are infective after the onset of the rash? Basically, varicella, herpes zoster, both of them are chicken pox and relapse of chicken pox, reactivation of the chicken pox. So hence 6 days after rash is applicable for both of them. Now give me one confident answer. 51. Kamal proposes measles 3 days after rash. There is one table in park. After for how many days things are infective. Basically, in German measles, now let us look into it. In measles, from the onset of ketral stage through 3rd day of rash, chicken pox is most infectious from 1 to 2 days before rash and continues until all the lesions have crusted. So that is the reason out of all this, in case of the German measles, there is no need of any isolation or chemoprophylaxis, except that women in the first trimester should not be exposed. Rubella. Nor should be sexually active. Non-immune women in childbearing age not using contraceptive measures. They should not be exposed. Otherwise, there is no separation or anything is required in German measles. So that makes C as the answer. Question number 51. Measles 3 days after rash is true. Now, this is a very tough question. We know all these are growth charts, but we don't know Anganwadi worker is using what. And you don't have mobile phone to call to your Anganwadi worker what she is using. Even if you have a chance to call, she doesn't know what she is using. So that's the whole problem. Question number 52. What is your answer, doctor? Pure quiz, doctor. Entrance is pure quiz. Nothing to do with gold medals, how many you got, how many long jumps did you win, how much tall you are. Nothing it has relationship. 6 months if you sit and revise 1200 topics and keep in your heart to heart at least some 20,000 hardcore facts about MD entrance. Any entrance you write, you will get. The moment you get, you go to Varanasi and dip in Ganga and get rid of all the trash in your brain and start afresh for the entrance, provided you did not get Health or Vibrio from the Ganga dip. Question number 52. Krishna, Nikunj, Priya, everyone is saying, how come NCHS, only Shahila, Kavi are saying CDC? What is this, doctor? You are giving me some tremors for me to pronounce answer as IAP. My answer is IAP. After breaking the head, I am able to get one reference in some remote corner of a server in internet. Luckily, internet made the things more easier. Indian Academy of Pediatrics growth charts, which are based on the Harvard growth standards, are the ones which are commonly used in the ICDS program by the Anganwadi workers. 3-year rural MBBS doctor recommendation. Examiner is bored in asking Srivastav committee, our original Chedda committee, no Chedda committee, all those committees of old park, he is bored. Recent Times of India, under what recommendation NEET was introduced? Who is that guy who said conduct it in November? Under what constitutional rule there had been a postponement? What is the present status of NEET can be an MCQ in the next November AIIMS? What is your answer? Question number 53. Kamal, Sudha, Kumar, Shahila, they say high level expert committee of planning commission said ये MBBS डॉक्टर्स को MBBS खत्म होने के बाद बोस्टन में रेसिडेंसी करने के लिए कुछ लोग USMLE लेके भाग जा रहे और कुछ लोग कैसा भी बैठ के they will sell an apartment, buy 150 lakhs PG seat and then start a nursing home and once more reproducing the money. Nobody is coming to villages. So let us start 3-year only village doctors. Special MBBS course. Right? So question number 53. It was the high level expert committee. Is it the same question which was given in an actual exam? Pakka. I am still wondered that it has been given. What is the WHO definition of meningococcal meningitis? Highly endemic, not epidemic. Some guesswork. Question number 54. What is your answer, doctor? Vijay Rohit is proposing more than 10. Then it becomes epidemic. It is highly endemic that was given, no? Yeah. Kamal left this question. Rakesh is saying more than 10. I am able to get a statistic, a value for epidemic. Anywhere I searched it in internet, not for highly endemic. Somewhere in a small remote corner where I am about to give up my search, it gave this reference as 1 to 2 is endemic, 2 to 10 is epidemic. More than 10 is definite epidemic. So highly endemic is, I don't know, whether 2 to 10 or 1 to 2, which is called as highly endemic. Is highly endemic was there, doctor? Anybody who took the entrance? Only endemic was there. Highly endemic is there. Maybe highly endemic is equal to epidemic. Then also answer become 2 to 10. I'm not sure. Now, आशा को पॉकेट मनी कहां से मिलेगा? Remuneration to Asha. SPM is, don't think you read everything and answer in exam hall. Some things guess मारना, guess मिल गए तो luck बोलते ना, किस्मत में नहीं है तो PG seat नहीं मिलेगा डॉक्टर. So there's a big list how Asha will get on what schemes, how much money will come from which source. Do you think you will master all those things and go for exam? No, not at all. It is like dating somebody with some prepared answers for some standard questions. You will end up in a date disaster. So entrance also is like that. Question number 55. Sudha says D, Priya says C, Shahila says B. Anyone want to say A? No? Right? Let us make some guess. Institutional delivery. इसके लिए पेशेंट को ले जाना और क्यू में खड़े होना और उसको एडमिट करना, वो सबके लिए थोड़ा टाइम लगेगा ना. चलो पॉकेट मनी दे दो. फर्स्ट डोज ऑफ ओपीवी बीसीजी, इसके लिए भी कुछ दिए तो काम चलेगा. बर्थ रजिस्ट्रेशन, nothing can happen automatically on a SMS, so it requires some effort. Birth weight recording is much more easier job, which don't deserve much of pocket money, I think. Question number 55. This is the list, doctor. Asha incentives. There are 30 ways Asha can earn. Right? Janani Suraksha Yojan delivery in PHC. 350 rupees is incentive in tribal, 200 per delivery. Motivation of BPL SC ST beneficiary for tubectomy. 150 rupees per person. And budget source is from which department also is being mentioned. Leprosy treatment, 100 rupees for a newly detected case. 400 rupees if it is multibacillary case. She is more happy. So she will say, you are not at multibacillary, no, become multibacillary, then I will get 400. Until then, you keep perpetuating your organisms. Then control of epidemic, outbreak, 100 rupees is given. Like that, birth information, 20 rupees for every registration. Child immunization, 0 to 1 years, 150 rupees. So these are all the things, doctor. I leave all this pasted on the blog, on the website, onlinemmbbs.com. You can review if you have energy. But to remember, 30 Asha benefits is forgetting another 30 points in cardiology. So use your common sense to answer. Question number 56. Oral dose of vitamin A. Is it oral prophylactic or oral dose? Prophylactic? For the pregnant female, what is your answer? 50,000. Question number 56. Rohit, Nikunj, Priya, Shahila, everyone is saying A. I actually have WHO recommendation schedule everything in which pregnant women is not included. See, we give basically prophylaxis to all patients above the age of 1 year except the women of reproductive age group. What do we give? 2 lakh inhalation units of vitamin A orally or 1 lakh inhalation units by IM injection. Children under the age of 1 year and children of any age who weigh less than 8 kg should be treated half the doses of the above value. Then women of reproductive age, pregnant or not, if they have night blindness, how to give? And for corneal xerophthalmia, how to give? But there was nothing mentioned. Do we give routinely for the pregnant women vitamin A? Without xerophthalmia, without bite hot spots or anything? I don't know. You're all more current and concurrent house surgeons, right? So anyway, Krishna says prophylaxis was mentioned. Yeah. How many health related millennium goals? First of all, we must know what are the millennium goals. Number 1, to get married. Number 2, to do a decent MD without paying any capitation fee. Number 3, to buy one nice Santro car or a Chevrolet. What else? To have a good secretary. Number 4, a mama who can give a good nursing home. So these are all our millennium goals. Into that suddenly this health related is not fitting. So what is your answer? Question number 57. Vidya says A, Kumar says C. Only 3 goals are health related. Remaining are what? Building the bridges, construction of dams. What is there in the millennium goals? Any other guess I am looking for? Fahima, Sujata, get a big clap. Fine. First of all, what are they? Millennium goals. Eradicating extreme poverty, hunger. Right from the days of Prime Minister Indira Gandhi, Srimati Indira Gandhi ji. Garibi hatao. It was there since many millenniums. Achieving primary education. Universal primary education. Promoting gender equality and empowering women. Give them swords and AK-47 rifles to kill the people who are trying to molest them. Reducing child mortality. Can you call this health related? Ek ho gaya na? Then improving mental health. 2, combating HIV. 3, ensuring sustainability of the environment. Is it health or not? You have to keep thinking in the exam hall. I will tell how it is. Developing global partnership for development. Health or no health? See, you have ensure environmental sustainability. Goal 7 is there, no? By 2015, give accessible, safe drinking water and basic sanitation is a part of that. So, of what? Environmental sustainability. And safe drinking water, basic sanitation is once more health related. So, this can be included under health related MDG. Then, goal 8 says develop a global partnership. Under this, in cooperation with pharmaceutical companies, provide access to affordable essential medicines to the developing countries. That makes goal 8 also health related. So ये 2 goals मिलने के बाद वो 5 हो गया, नहीं तो वो 3 ही था. That is called as MD entrance Juba Khel. So the what you call gambling of MD entrance, it is called as. All right. What is the most recent Mental Health Act in India designated as? They are all simple. On a Bombay beach, you have some little sort of general talk. We talk now politics, India, poverty, everything. That's called as SPM. So give me a general answer. Generally, general answers will be generally wrong. So that is the general rule. What is your answer? 58. Rakesh, Nikun, Shahila, Rohit. Rohit says D, but everyone says C. But I say Mental Health Care Bill was introduced in 2012 after India ratified the UN Convention of the Rights of Persons with Disabilities, which came into force in 2008. There is a clear need for the existing disability laws to be modified in India to bring them in compliance with that United Nation Convention. So in pursuance of that, it introduced Mental Health Act 1987 MHA is sought to be replaced by the new Mental Health Care Bill Mental health care bill, I don't know, must be A and C, which was given, I don't know. What is given? Both are given, they look so. Really given? Okay. Question number 58, that way become A. It is given. C is also given. Okay. How many number of vision centers under national? One evening we have reviewed National Program for Control of Blindness and all SPM part of ophthalmology. That was the most dragging evening of our ophthalmology session. But that is very important when it comes to the national programs. Primary level vision centers, there is a need to develop 20,000 vision centers, doctor. 20,000 diploma ophthalmology seats also are not there. Total MD seats are not there. 20,000. Then who will be taking care of the vision centers? Each one will have ophthalmic assistant. Oh, very good. Not a diploma ophthalmology. It covers a population of 50,000. And service centers, there is a need to develop 2,000. Training centers, 200. Center of excellence, 20. Aha. You can remember 2020 IPL match. 20,000 vision centers, doctor. Divided by 10 is 2,000 service centers. Divided by 10, 200 training centers. Divided by 10, 20 centers of excellence. If you know 2020, you can answer this question. So that's how we survived SPM. All are pure guess and bouncers. Painful ulcer in the thoracic dermatomal pattern classically is very easy question. Herpes zoster, varicella zoster, relapse of the chicken pox. Recurrent oral ulcers, epididymitis with blurred vision. I'll try to go a little faster. It is typical of the vasculitis, which is Behçet's. But we may get a doubt, will Behçet's cause epididymitis? Yes, sir, it can cause. Due to vasculitis, it can lead to blurred vision. And uveitis can be there. And oral ulcers are the part of the Behçet's. Then fine grouped pinhead papules on the dorsum of the hand, chafe of the penis and forearm in a child. Classically is an example of, you thought it as scabies. Fine grouped pinhead papules on the dorsum of the hand, forearm and shaft of penis. Classical description. It was not given whether they are pruritic or not, or any other clue was not given. Question number 62. Vidya, Sujata, Krishna, Kumar, everyone say molluscum contagiosum. Molluscum contagiosum is a pearly papule umbilicated lesions is the description. Right? So, lichen nitidus most commonly presents where there is an insidious onset of the lesion. Typically, it is asymptomatic. Pinpoint to pinhead sized skin colored papules that may be scaly or central depression found on the forearm, trunk and glans and shaft of penis. Classical description of lichen nitidus. I leave that in the literature for you. Now, doctor, this is a same verbatim repeated question of AIIMS. Boggy swelling, pluckable hair, discharging sinuses. What do you want to do? Basically, all these are the important features of inflammatory tinea capitis. That's the reason we need to do the KOH. This inflammatory tinea capitis called carrion need to be differentiated from favus and non-inflammatory form of tinea capitis. So KOH is the answer. Painful blisters with an erythematous base makes you to think of which important entity, doctor? Give me one confident answer. 64. Yes. Erythematous base, painful blisters. What is your answer? Possibly. Jank smear, you heard of that? Immune fluorescence, you heard of that? What makes you to think of it? 64. Vijay Rohit says there were also tense blisters which was mentioned. Was it mentioned? Tense painful blisters. Oh, I basically thought it as herpes simplex. It is not that simple. It is what? Bullous pemphigoid. Huh? Pemphigus vulgaris. Oh, okay, okay. That tense was not given in the information I had. So, okay, we will review that answer a little later. But Vijay Rohit says there is no painful, sir. Only tense is there, sir. We will come to this later. Huh? Now comes our favorite question. Hypertensive, headache, vomiting, neck stiffness without neurological deficits. Classically, focal neurological deficits won't be there. Doctor, I never had this much severe pain. When will the patient say? Subarachnoid hemorrhage. Never such a severe pain. Excellent. Everyone correctly answers it as subarachnoid hemorrhage. Fever, neck stiffness, rash, shock with adrenal hemorrhage. Classical. Neisseria, meningitis. This is a beautiful question. Decreasing CPK levels with limb weakness with the increasing age. Initially CPK elevated, doctor. With the increasing age, CPK starts falling down actually. In which condition do you find that? Classically. Question number 67. That's right. Everyone is voting for B, which is true. The moment the muscle becomes so degenerated that there is no CPK to get released at all. In case of the Duchenne's muscular dystrophy. So with the increasing age, what will happen with the dystrophin deficiency? The muscle itself becomes so degenerated that muscle is the source of CPK. So if the muscle itself is so degenerated, CPK will start falling down. Beautiful question. Chronic alcohol patient with 2 days history of free alcohol comes with seizures. It's an example of rum fits, they are called as. Commonly, if a villager gets a malaria or something admitted in hospital, villager means watch the moonlight, wife prepares a beautiful half a kg chicken with all spices added up, with nice breeze coming, no industrial pollution. A happy man, he is called the peasant, enjoying with the beautiful wife a moonlight with the food, no hurry to run next day morning anywhere. Every day he has a habit of drinking toddy. Poor guy got cerebral malaria, admitted under your care in district hospital. So once there is any abstinence from his wife and alcohol, he will start getting seizures. So how do you treat? 68. That's right. Everyone say alcohol withdrawal seizures are all diazepam. Most common slow growing vascular tumor of the brain and spinal cord. Both brain and spinal cord get involved whenever there is any hemangioblastoma. It can be part of the von Hippel-Lindorff syndrome also, which is not a major criteria of acute rheumatic fever. Medicine is very predictable this time. So what is your confident answer? Polyarthritis is different from algia, which is minor, which is major. Question number 70. Kumar says polyarthralgia is not major, it is a minor criteria. So major are polyarthritis, carditis, and subcutaneous nodules, erythema marginidum, Sydenham's chorea. But minor are fever, arthralgia. Arthralgia is a minor criteria. Alzheimer's is typically associated with which lobes of the brain which are degenerated, doctor? Question number 71. Who will give me one confident answer? Parietal and temporal, or frontal and temporal. Frontal and temporal is not given by me, but we have FTD, frontotemporal dementia. There is one entity, no, which we discussed. Question number 71. Everyone, Fahima, everyone is saying parietal and temporal are the ones which classically show the presence of degeneration. This is a beautiful question. Yesterday suddenly I was jerked to discover what I could not discover in entire 3 years of MD General Medicine. Don't tell it to my examiners. They will take back my degree. Mental status examination is different from Mini mental status examination. Mini mental status, just like big pizza, mini pizza. So what we use in ward rounds in neurological assessment is mini pizza, mini mental status examination. That I know, having had done MD General Medicine, because in MD General Medicine final year, in the exam hall, without checking patient, you must be able to jot down the MMSE and give some score, because you are given a short time to finish a long case in neurology. But mental status examination is done basically by the psychiatric guys. So question number 72, who will give me correct answer? Everyone says A except Vijay Rohit is saying C. Perception versus insight. Which is the one which is a measure of awareness response? Any other answer you want to try? When I say any other answer, you can try. Sudha also confirms with insight. Any other answer? Somebody said cognition. Cognition? Superb. Cognition. MSE should not be confused with MMSE, which is a neuropsychological screening, MSE, for the dementia. So doctor, appearance, attitude, behavior, mood, affect, speech, thought process, thought content, perception, cognition, insight, judgment. These are all the parameters which are observed under mental status exam, not mini mental status. In that, the cognition is the one which will be able to judge the level of alertness, orientation, attention, memory, visuospatial functioning, language and executive function. These are all assessed under cognition. Alertness is a global observation of the level of consciousness. So that is the reason examiner is asking is, now comes awareness, right? Alertness is a global observation of the level of consciousness, that is awareness of and responsiveness to the environment is basically called alertness, which is evaluated under cognition. So examiner's question is, awareness is basically evaluated under which parameter in MSE? That becomes cognition, which becomes the answer. Good question, really good question. Priapism is caused by cantharides, which are the part of the Spanish fly, is what need to be remembered. Question number 73. 73. Vijay Rohit also is Spanish flying, so he doesn't want to agree with any other answer. Anybody thought scorpion bite? Thinking that scorpion bite lead to sympathetic activation, which can lead to uncontrolled erection leading to priapism. If your mind starts going in a different neuroanatomico medical direction of Einstein like pathophysiological thinking, you are out of exam. Common sense is, if you don't know about Spanish fly, is sympathetic system activation, and you will remember now which is sympathetic, which is parasympathetic in erection and ejaculation. So you will start thinking in that direction and try to fit priapism somewhere with the scorpion. If the scorpion bites, there is no antivenom. So question number, the next question. Patient has renal failure, bone pain, 35% plasma cells on bone marrow biopsy. What else is required? What is your diagnosis, doctor? Classical answer. AIIMS doesn't ask all questions in a typical manner. Simple questions, typical questions will be asked, doctor. 74. Nikunj, everyone says multiple myeloma. But still, the next November session AIIMS can ask you about smoldering myeloma. So, what are the definitions according to the international classification? You have symptomatic myeloma, then in that you have crab features. What is crab? C for hypercalcemia, R for renal insufficiency, A for anemia, B for bone lesions. So all these things along with Plasma cell population bone marrow more than 10% along with paraproteinemia fits into the definition of symptomatic myeloma. Asymptomatic smoldering myeloma. In this paraproteinemia, plasma cell more than 10% will be there, but there will be no myeloma related organ or tissue impairment and there will be no symptoms. That makes it smoldering myeloma. Then when do you call monoclonal gammopathy of undetermined significance, MCUS? If the paraprotein is less than 30, plasma cells are less than 10%, with no myeloma related organ dysfunction, then it becomes monoclonal gammopathy of unknown significance. This comes after reviewing entire neuroanatomy every day with me. If you answered this wrong, my soul will be heaving in the graveyard. So what is your answer, doctor? You like to say? You like to say? Cerebral lesion. Bilateral Babinski. Bilateral cerebral are gone. Eh? See, cerebral will lead to hemiplegia, no doctor. On the side where you have hemiplegia, you are having Babinski positivity. Bindu, you have sent me to the graveyard in a restless state. Yeah, any other answer? Bilateral Babinski. All motor tracts will be passing through pons, you agree? All ascending tracts will reach the thalamus, you agree? So, Babinski is because of descending motor tracts which are passing through pons. Pons is a part of brainstem. Question number 75. That's right. Guntur, everyone says brainstem lesion, which is true. So, bilateral Babinski is accompanied by bilateral weakness or paralysis. We said no, pontine hemorrhage or pontine myelinolysis. Patient in a differentiated state, locked in syndrome it is called as. He can only move the eyes. He can't do anything else. All muscles are paralyzed. Right? So, that is all about that. Next. What is wrong about iodine treatment? Iodine treatment. Yeah, very good. Vijay Rohit is saying, it is not even given as brainstem stroke, sir. Don't accuse Bindu. It was given as pontine hemorrhage only. If pontine hemorrhage option you would have given, Bindu would have correctly answered. No problem. Huh? So, because somebody should, I regularly disappoint the students with their wrong answers. Sometimes students should also know how to bring down the teacher, no? So, yeah, iodine treatment. What is wrong about it? Give me some confident answer. Do you think you don't give it in hyperthyroidism? You give, no? Simple question. Question number 76. Everyone said B. Is it for 75 or 76? Yeah, B. It is very much given. It inhibits the release of thyroid hormone. It can lead to iodism. We basically give Lugol's iodine for this purpose. Why TTE is better than TE? Sorry, TE is better than transthoracic echocardiography. Because esophagus is a posterior structure. Left sided chambers of the heart are also posterior. So if you want to look at the left atrial appendage, which is more posterior located, go to posterior aspect by entering into the esophagus. So for that purpose, to better visualize. Now comes our favorite question. I give one more chance of all the students who attended with me the neuroanatomy. Right-left confusion. Huh? Superb. It is due to which lesion? Parietal. Which part? Which gyrus in that? Angular gyrus. Very good. That should be the spirit, doctor. At least I can wake up from the graveyard. Gussman. So, doctor, dysgraphia, dyscalculia, finger agnosia, left-right confusion. They are all the features of the Gussman, which is due to the angular gyrus involvement in the dominant hemisphere, is what need to be remembered. This is another very standard question. Those who attended medicine, final year medicine with us will definitely answer. Which is not found in iron deficiency. B. Excellent. So there is an increased TIBC, not decreased TIBC. 79 There are people punching 5 to 6 Bs. That's good. So for our earlier question, Harika is 10 times B about Gersman. That's good. In nephrotic syndrome with steroid toxicity, what is the best alternative treatment available? There is a difference between steroid resistant, steroid responsive, but toxic. See, steroid sparing drugs are basically used for two reasons. Steroid resistant cases and also steroid responsive, but when patient can't tolerate that doses of steroid which is leading to toxicity. Then also you need to use steroid sparing. In fact, all these drugs are steroid sparing. But which is specifically given if there is a steroid toxicity intolerable to dosages. Question number 80. That's right. Fahima, Sujata, everyone says cyclophosphamide. Classically, significant toxicity, severe relapses with thrombosis, or poor compliance or difficult follow-up where 12 weeks therapy might be possible to ensure long-term compliance with cyclophosphamide, unlike in steroid. So in such cases, cyclophosphamide is preferred to that of the steroid. We give mycophenolate, mofetil, everything. So I leave to you on the blog, on the website, all these protocols. Now, LBBB, what are the causes? RBBB, what are the causes? Favorite question of the examiner, times immemorial in AIIMS, because what AIIMS is expecting, only don't do MD general medicine, please do cardiology also with us, right? So question number 81. Rohit, Vidya, Shahilan, Nikunj, everyone say hyperkalemia. How come? How come? Don't you think one of the criteria to identify a MI is the discovery of LBBB, acute MI? 81, anyone want to revise the answer? Guntur says recent MI, that's right. From our Guntur Medical College, regularly the toppers will be there in the AIIMS. So I hope that they are able to get that cue. Tarachand, after a long time I am seeing, is also saying recent MI. Very good. Like a parrot you must tell doctor, LBBB causes. Any left ventricular hypertrophy like aortic stenosis, dilated cardiomyopathy, or acute MI, extensive coronary artery disease, any long-standing hypertension leading to aortic root dilatation, they all lead to LBBB. Now in this one is given, no, Ashman's focus. What is that? Ashman's phenomena or Ashman's focus. Will it cause LBBB or RBBB? First of all, what is that you must know. Ashman discovered one rule called as long short rule. What is that? Whenever there is a premature atrial complex, PSCs, PVCs you heard, no? The earlier in the cycle PSC occurs and longer the preceding cycle before the appearance of the PSC, the more likely that the PSC become aberrantly conducted into the ventricle. Okay? The more likely that that PSC will go into the ventricle. Why? Because the length of the cycle and the heart rate have a relationship with the duration of refractory period of the ventricle. Suppose if a PSC occur in little later part of the cardiac cycle, even if it want to go, that premature atrial complex want to go into ventricle, ventricle will be in a refractory state. Okay? But if it occur a little more early part of the cycle, then when it want to go into the ventricle, ventricle is not in a refractory state, it will receive it. So aberrant conduction can occur. This was discovered by Ashman. Now, in these people, it is a right bundle instead of left bundle which receives that aberrant PSC. So that is the reason a aberrant PSC conducted into ventricle will lead to RBBB type of pattern will lead to, instead of a LBBB type of pattern. This was told by Ashman. So Ashman phenomena has association with RBBB, not LBBB. If you don't know who is Ashman, if you don't know who is PSC, very happy. Still you can answer this question. If you know LBBB can occur in MI, right? So 50% knowledge is enough for answering an exam, because remaining 50% you must use guess. But if you have 10% knowledge and 90% guess, means your parietal lobe will be bulging out of calvarium in the exam hall, temporal and parietal lobes, which is difficult. Bilateral ptosis, superb question. After a long time I am saying this question. No diplopia. Acetylcholine receptor antibodies are negative. Slight limb weakness. Male patient. All required clues for the striptease are available. So what is your answer? Basically, whenever there is ophthalmoplegia, if it is asymmetrical, then only diplopia will be a clinical picture. Why? That side eye which suffered ophthalmoplegia will project image somewhere. Other eye which is not involved will project somewhere. So double image will occur. Whenever ophthalmoplegia is bilateral, then diplopia will not be a feature. So if you take ocular myasthenia or generalized myasthenia gravis, in them diplopia is a known feature. Absence of diplopia with a bilateral ptosis favors either option A or D. Right? Examiners simply want to know, do you know about A? CPEO. What is CPEO? It is not Communist Party of European origin. What is CPEO? Question number 82. Yeah, let me check what are the guesswork. Everyone thought it as B except Sudha thought it as D. No one thought it as A. I thought it as A because I did not take the exam. My job is to give answers, is more easier job. Chronic progressive external ophthalmoplegia is a progressive external ophthalmoplegia where there is a slowly progressive inability to move the eye and eyebrows. It is a mitochondrially inherited state. And classically the first presenting feature is a ptosis. And in this, classically it is bilateral ptosis, and double vision is not a complaint in these people. And there will be acetylcholine receptor acetylcholine receptor antibodies in myasthenia. They will be typically negative in these people, right? Unlike myasthenia. So the presence of negative acetylcholine receptor antibodies makes CPEO more likely to be the answer. Now doctor, superb question. Without a question on acidosis, alkalosis, don't imagine of going to Ansari Nagar, because you have to be sure. Okay, what is your answer, doctor? First let me quickly get the answers from our online colleagues. 7.45 pH, doctor. Definitely it is alkalosis only. Alkalosis can be metabolic or respiratory. First of all, to decide whether it is metabolic, you need to get bicarbonate value, which is not given here. That means examiner only want to think of respiratory alkalosis. If it is respiratory alkalosis, what do you expect PCO to be? Pure respiratory alkalosis means. Whenever we hyperventilate, we get respiratory alkalosis. Hence, PCO2 is expected to be very low. Right? Question number 83. Shahila says A, but Nikun says B. You remember this chart, doctor, 4-step guide for ABG analysis. First step, pH is normal, acidotic, alkalotic, you should check. How is PCO2 bicarbonate? Between the two, check which is influencing the pH. If both PCO2, pH, HCO3, both of them are abnormal, check which one is deviating most from the norm. Then it is most likely to be abnormal pH. See, if both PCO2 is deviated, bicarb is deviated, let us say. What do you expect bicarb in a metabolic alkalosis to be? High. PCO2 to be low. Instead of low, if PCO2 is low, bicarb is also high in, let us say, in a given person. Then how will you decide whether it is metabolic alkalosis or respiratory alkalosis? You see which is more deviated. Then that is the primary problem, and the other is only a compensatory phenomena. Now let us see. Respiratory acidosis, doctor. pH is acidotic. And PaCO2 will be high. Why high? We get respiratory acidosis when we are hypoventilating. And carbon dioxide is unable to go out and living in our body, not living in our body. That high CO2 will lead to carbonic acid formation leading to acidosis. Hence, PaCO2 will be more than 45. But since it is purely a acute acidosis without compensation, bicarbonate will be normal. Okay? But if it is a compensated acidosis, what will happen? How will our body compensate for an acidosis? It will try to retain the bicarbonate by the kidneys. Hence, if the bicarb is increased to more than 25, then you call it as a respiratory acidosis which is compensated. Agree? If it is respiratory alkalosis, how will it be? Alkalotic pH will be there. Because it is alkalosis, respiratory in nature, it is due to hyperventilation. Hence, PCO2 will be less than 35. But bicarb has not shown any response. When do you call it as compensated one? Typically what is the compensation for a respiratory alkalosis? Our body will try to get rid of the bicarb into the urine, kidney. Hence, bicarb will be less than 22. Right? Now, if it is metabolic alkalosis, in this case, how much PaCO2 do you expect? You expect PaCO2 to be more than 45. Right? But in this case, when do you call respiratory alkalosis? Whenever the PaCO2 is less than 35. So that is the reason, since the PaCO2 is less than 35, which is 30 here, we call it as a respiratory alkalosis instead of metabolic alkalosis is what you have to basically conclude. So this is the most important table to be. Every time examiner will ask the same issue. Now, I think they are going very slow. They need to be a little more faster. Fever, headache, CSF 300, protein 70, sugar 50. What is your answer? Standard question. Viral meningitis, TB meningitis, bacterial meningitis. How do you basically differentiate? So there is no hypoglycorrhea. Sugar is 50, it is not less than 50. But less than 50, there is a low glucose. Low glucose is a feature of both pyogenic meningitis and TBM. Right? So that is the reason it is more likely to be viral in etiology, which makes herpes encephalitis become the answer. Question number 84. How come everyone answered it as C? Pyogenic meningitis? Why? You thought sugar 50 as low sugar. Compare it with the blood sugar, doctor. Is it less than half or as much as half? That differentiates, no? So, fundamentally, typically in case of a viral profile, what will you find? Mononuclear pleocytosis between 10 to 500 WBCs, and protein levels are elevated to the range of 60 to 700. Glucose may be normal or mildly decreased to 30 to 40, that's all. That's what makes it viral. Vijay Rohit says it was normal glucose which was given. In fact, more than 50 was given. So now, what is the difference between seizure and syncope? Classical question. I say none of them can differentiate. Is there anything to differentiate? Postictal confusion or sensorium. See doctor, this is the most important thing. Duration of unconsciousness will be minutes in seizure, seconds in syncope. Then disorientation and sleeping, that is called postictal confusion. In fact, will be there in both, but will be minutes to hours in seizure, but less than 5 minutes in syncope. By that merit, answer becomes C. That is, postictal confusion can differentiate between that of epilepsy versus syncope. Both of them can cause urinary incontinence, both of them can lead to loss of consciousness. Okay, so that is not a differentiator. Now, in epilepsy patients, what do you want to do? If there is a refractoriness to medical therapy, give some confident answer, doctor. You want to immediately jump to epilepsy surgery, or do you want to give something like a vagus stimulation, deep brain stimulation, etc., etc.? Somebody argued deep brain stimulation is only for Parkinsonism. But if you slowly read, next line will be it is also used in epilepsy. So we use all of them. In fact, I don't know what was there for the examiner. Vijay Rohit says for our earlier question in the actual exam, postictal confusion was not given. It was given or not? Not given. So what is given? I don't know. But the idea is you should reach this table in the textbook. Huh? Alright. 86. Deep brain stimulation is used in case of Parkinsonism, true. It is also used as effective in epilepsy also, but not a definite indicated one. But vagus nerve stimulation is very much adjunct. Would genetic defect lead to MODY, doctor? Easy question. I'll try to run a little faster. HNF1A, factor A is the most common underlying genetic defect in MODY. What is an embryonic HB? There's a difference between embryonic HB, fetal HB, sickle HB, HBH, HBC. So zeta and epsilon are the components of the embryonic hemoglobin. And embryonic hemoglobin, what are the various subtypes, doctor? Gover 1, Gover 2, Portland, they are all the examples of different forms of embryonic hemoglobin. Now, which is not included in the integrated disease surveillance projects. Snake bite is not included. Is snake bite included? No. So, integrated disease surveillance project may fever with or without localizing signs. Think of malaria, typhoid, Japanese encephalitis, dengue and measles. Cough more than 3 weeks, think of TB. Flaccid paralysis, think of polio. Diarrhea, think of cholera. Jaundice, think of lepto. Snake bite is not there. Is snake bite is there in options? No. Is there? That means examiner want to check whether you are alive after 85 questions or not. Such an easy question. No one will think of snake bite, right? Alright. Now comes ophthalmology. Let us check what we have prepared. We finished DNT, ophthalmology, and about to finish anatomy in this our present coaching, which started from April 1st. So, I'll start with atypical questions, don't worry. Most common non-Hodgkin's lymphoma in the orbit is of which cell type? C or A? B cell type. Anywhere non-Hodgkin's commonly is B cell, except few locations where it is T cell, but most of the times it is B cell, whether it is orbit or anywhere. Most of the people say B cell, that's right. Lid swelling discharged with gram-negative cocci with tiny colonies on culture and that organism is oxidase positive. Maybe this question belongs more to microbiology, right? So, but still, lid swelling discharge, conjunctival discharge. Question number 3. So, Rohit, everyone is saying, yeah, what is your answer? Neisseria. Classically, Neisseria is gram-negative diplococci, which is oxidase positive, as all of you know very well. Thayer Martin medium. Yes. Chalazion is what, doctor? Give some confident answer. If you don't give once more, we will start ophthalmology from tomorrow. Right? So, Vijay Rohit, everyone is saying lipogranuloma. He understood ophthalmology enough, sir. So, right, that's good. Correct answer. Meibomian gland lipogranuloma is the name given for the chalazion. Glaucoma drugs. What is the mechanism of action? Different names, but same weddings. So that is called as history of wedding. AIIMS wedding is also like that. Different people will be getting wedded to the entrance, but the questions will be same. Mantra will be same, doctor. Come on, give me an answer. 5th, Rohit proposes brimonidine decreases aqueous humor synthesis as most correct. Anybody want to elect A? Question number 50, question number 5 here, yeah. What do you want to say? There are two kinds of outflow for aqueous. One is called uveoscleral flow, other is called trabecular outflow. It is the trabecular outflow which is increased by the meiotics, not uveoscleral. So, B is the correct answer, brimonidine. Okay, the next question. Ocreoplasmin is a new drug. Even if you read ophthalmology also, you don't know this. Pure guess. Chalo, guess maro. There should be definitely one question on retinal detachment, no? And the entire ophthalmology revolves around the fibrous bands formed in the vitreous. So, to break that vitreomacular traction, we use a recombinant protease which acts on the fibronectin and laminin, which is called ochreplasmin. Now comes the favorite question. This you will all answer. We have come up with about 50 topics in ophthalmology. I can say out of 10 questions, 8 were standard topics from that 50. Okay. Without a question on glaucoma, there is no paper. Cataract, no paper. Retinal detachment, no paper. So standard, even in that 50 topics given by me, first to 20 topics if you read also, still 8 out of 10 questions you can answer. Give an answer. Rheumatogenic retinal detachment. Very good. Question number 7. Most of the people are answering it as, what is your answer? Myopia or hyperopia? Which lead to rheumatogenic retinal detachment, doctor? Age, sex, myopia, aphakia. Aphakia was also there. Pseudoaphakia was there. Okay. Retinal degenerations like lattice, trauma, they are all the various causes for the rheumatogenic retinal detachment. Blunt trauma to the orbit is one of the favorite topics of the examiner. Orbital floor anatomy we discussed. It is formed by all the structures except, give me one guesswork. You want to say zygomatic? Huh? Question number 8. Rohit is saying in contrast ethmoid. Kavi also, Shahila also. Everyone is saying ethmoid. Bindu, what do you want to think? Ethmoid. Superior margin is frontal lobe, frontal bone. Inferior is maxilla pallidine and zygomatic. Middle margin is frontal lacrymal ethmoid and lateral is zygomatic and sphenoid. Pigmentary changes in the posterior pole called salt pepper retinopathy. What are the various causes? Standard old question. Question number 9. Except. Yeah? You want to say D? That's right. Fundus flebimaculatus. Otherwise in congenital rubella, syphilis, thyroidism, chloroquine, in all this you will find. Which does not lead to a calcified focus. In the orbit, calcification is a classical feature of retinoblastoma, you all know. What is the differential diagnosis for a retinoblastoma? All the other three. So how do you differentiate option B from A? Through calcification. Uncalcified lesion leading to leukocoria is persistent hyperplastic primary vitreous. The one which is calcified is retinoblastoma. So PHP